There can be no more room for standard thinking that these resultant foot and ankle problems arise just because we are getting older, or we are obese, or they are just random, or that equinus contracture is only part of the equation. Equinus is the equation. I just love that quote, and I think it really sums up the importance of equinus. Before we really get into this, we have to talk about the proper way to evaluate for equinus, because it's changed pretty significantly over the last couple of years, and it's quite different than the way you were taught, particularly in school or residency program. A lot of the confusion on equinus stems from the multiple ways to measure ankle joint dorsiflexion described in the literature, and there's up to 23 different methodologies used. So that leads to a lot of confusion. And the ankle joint dorsiflexion angle can differ between 8.5 and 10 degrees, depending on the position of the foot, whether it's in a pronated or supinated position. And that's just too big of a gap, really, to be of use when especially with something that has a small amount that we're talking about here. The historic root method, where we put the subtalar joint in neutral and lock the metatarsal joint, which is how we were all taught, has been shown to have very poor inter and intra-rater reliability. The method that really has become the standard is to maximally supinate the entire foot. And when you do that, including the hind foot and the midfoot and the forefoot all together, it locks the metatarsal joint to only 2.5 degrees of motion, which is considered clinically insignificant. So any dorsiflexion that we're getting when you put the foot in a maximally supinated position and then dorsiflex the ankle is all coming in the hind foot. So it's all being isolated to the hind foot. We're not getting any false motion through the metatarsal joint. So this picture demonstrates on the top left, dorsiflexing the foot in a pronated position, which is really not very useful. And here's the standard root method, which also, frankly, is not very useful. And this is really what you have to start doing. You can see the examiner's hands are maximally supinated, the forefoot, midfoot, and then the heel, and then you dorsiflex the ankle foot. This is a video showing the improper technique here. And that's really not helpful. You're getting a lot of false motion through the metatarsal joint with this. So here's really what you need to do. You need to supinate the entire foot and then dorsiflex it like that. And you're going to look along the lateral border of the foot with the knee flexed and knee extended. So that's really the technique that you need to utilize. I really like it when multiple authors come to the same conclusion. And Dayton looked at this, and they wanted to compare a radiographic parameter to what we're measuring clinically when we're evaluating for equinus. And they felt like the tibio-talar angle was the best radiographic measurement to look at. And what they were trying to do is say, okay, if we have a change in motion and the bones are staying the same, then we know that change has to be attributed to the foot position. So they took x-rays with the patients in a supinated, neutral, and pronated position, and then they measured the ankle joint dorsiflexion clinically in a pronated, neutral, and supinated. And so what they showed was that radiographically there was no change in the tibio-talar angle. However, clinically there was a significant change from pronation to supination was about 13 degrees, and from neutral to supination was about 9 degrees. So with the radiographic parameters not changing and the clinical parameters changing, all that can then be related to soft tissue. So then we can attribute that change into the tightness of the posterior muscle group. And Dayton's conclusion was that the motion between the foot in neutral and supinated position caused a potential error from the measurement technique when using the neutral position of the standard, which is the root method that we've used previously. And they recommended supinating the foot as a more reliable position for measuring clinical ankle joint range of motion and propose it as a potential standard. So similar type of findings as GAD in their study. Now that we know how to properly measure it, we can start to define it. And that's important to really, when you start defining it, we have to be able to correlate what this static measurement that we're taking is and how that is relating to what's happening dynamically in the second rocker of the gait as we go into the third rocker of gait, when all the sort of action is occurring in relationship to the posterior muscle group. We know as we transition through the second rocker gait, the ankle joint, as we bring our body from behind our foot over the top of the planted foot and forward, that the ankle joint has to bend between 10 and 20 degrees. That's very well established in literature, and that's really not debated. So what GAT did is they used this biocon system to measure exactly what was happening at that crucial second rocker gait before we go into the third rocker gait when the heel comes up off the ground, to see how much dorsiflexion was occurring. They had two groups. They measured them statically and then looked to see what was happening with them dynamically. So in the first group, they measured -5 or less with the foot maximally supinated. And the second group was -5 to 0. So those were the two groups based on their clinical measurements. And what they saw with the biocon system in the second rocker gait was the first group, -5 or less, only had 4.4 degrees of motion occurring at the ankle joint in the second rocker gait, which is substantially below that 10 to 20 degree mark. In the second group, they had 13.9 degrees of dorsiflexion, which that's significantly better and probably in the ballpark, but that's still probably not even enough, but it's much closer. So GAT their conclusion from GAT's article was that -5 degrees of dorsiflexion during static exam exhibited reduced ankle range of motion during gait. And that reduced ankle motion during gait is the problem because of momentum. When we're walking and taking a step, our body's still going to move forward over our planted foot. And if we have limited ankle joint dorsiflexion, because of momentum moving our body over our planted foot, we're going to then develop compensation. And compensation can occur distally in the foot, which we'll talk about in a little bit, or it can occur proximally at the knee with genu recurvatum, or at the lower back and hip area, lumbar lordosis. So that's where we can see some proximal symptomatology and pathology associated with equinus. But a lot of what we deal with is really attributable to the the distal compensation that occurs with equinus. So you may say, well, -5 doesn't sound like anybody's going to have equinus. Everybody still has equinus. But if we look at some of the literature on equinus, just to show you how prevalent it is, this is sort of the seminal article on that. And this is from 1995. And Hill looked at a group of new patients that came through his office and measured them. And he showed that for the patients that met their inclusion criteria, that 96.5% of the patients that had a foot or ankle pathology exhibited equinus. He had some really interesting quotes in his article. First was, he said the podiatric physician should look beyond the specific complaint to diagnose the underlying cause, and frequently ankle equinus deformity is at the root of the patient's foot problem. And this is something I tell my residents and the students who rotate through our program all the time. The Watts are pretty easy in our profession. I think, a bunion is a bunion, hammer toes, a flat foot, tendonitis, whatever. But why those things are occurring is really important and has to be part of your treatment plan. So this is kind of what he's saying here is, oftentimes the why of most of the Watts that we treat is really equinus. And he also said that gastrosoleal stretching is found to be an effective modality in treating a wide range of podiatric complaints where ankle equinus is the underlying etiologic factor, like I like to say, the why. Hill also had some really interesting quotes regarding equinus and orthotics, and there's really nobody else has really brought these up, and I thought they were pretty fascinating. He said, treating the apparent biomechanical problems that have an underlying equinus deformity, the rigid functional orthoses, is a major reason for unsuccessful orthotic treatment. That's absolutely true. The second quote was, equinus patients who receive orthoses as their sole treatment may not be capable of accepting orthotic control. That's also true. The one that he got a little bit wrong was the third statement, where he said a rigid orthotic will prevent the foot from pronating. The result is arch irritation from excess friction against orthoses. And we'll delve into that third statement here in a little more detail, and I'll explain why that one's not quite accurate. Jastrifer is the orthopedic surgeon out of Iowa who's written a lot about equinus. I think their most recent article was the frequency of equinus in rheumatoid patients. But in this article, they looked at gastroc contracture in patients with and without foot pathology. And Jastrifer has also written an article about this Iowa ankle range of motion device that they invented. and it's been a validated device, so they validated it within their previous study. So what they did is they had two groups of patients that came in, or in one group that had foot or ankle pathology, and then they had a control as the other cohort, and they measured the patients with the Iowa ankle range of motion device. They measured them with the goniometer, and they also just eyeballed it. And there was a substantial difference between the group that had a foot or ankle pathology and the control group, which did not. And their conclusion was that patients with foot and ankle pain had less dorsiflexion than the control group. And this was the largest study to date using a validated measurement device, as well as a control group, and supports previous findings of previous authors. This study supports the notion that isolated gastroc contracture may be associated with foot and ankle pain. And in their follow-up article that they wrote on rheumatoid patients, they had kind of a similar finding, also noting that rheumatoid patients have higher frequency of foot and ankle pain. They also had higher frequency of equinus, and linked those two things together. So I don't think we pay enough attention to equinus. Rue called it the worst foot in the world. Jeff Christensen, who we're going to talk more about some of his articles here in a second, called it a profound causal agent. And then Hill, who we mentioned earlier, called it a primary causal agent. So it's a significant part of what we do in most of the patients that we treat, and we really need to start giving it more attention. Amos said, it's been postulated that these epidemiologic factors such as obesity, sedentary lifestyle, medical comorbidities, shoe wear, concrete floors, advanced age, female gender, and overuse issues, to name a few, are responsible for a variety of foot and ankle pathology. And although these factors might consistently coexist with a variety of foot and ankle problems, they seem to have a causal relationship, and that's an important concept there. And it's my assertion that they have little, if any, direct relationship. And he concluded saying the singular and real association of these epidemiologic factors is contracture of the gastrocnemius muscle, which is camouflaged in this list. And most every other cause of these foot and ankle problems is likely mediated by contributing to the degree and or rate of an already contracting gastrocnemius. These problems promote gastrocnemius tightness, which in time causes incremental damage to the foot and ankle. And that incremental damage part is really important. There have been some people that have written some articles that question if equinus is truly a pathological condition or if it's just a normal variant. And the argument that is made is, hey, we have all these, Hannah Jarvis had an article that was in 2017 where they looked at the 5 tenets of root biomechanics, and one of them being equinus. And they were like, all the patients in this cohort had equinus basically, but none of them had any symptoms. And that's the problem, is you're looking at that particular person at a specific point in time. And just because they don't have symptomatology at that time doesn't mean that there isn't incremental damage that's occurring. And you just have not reached that tipping point where you've gone into a symptomatic state. And I like to kind of equate this to diabetic patients who come in just to have routine foot care and have their calluses trimmed. The callus is not a pathological entity of itself. It is just a representation of increased pressure that's going through a particular area on the foot, or friction. And we know, though, that it's a sign of potential trouble, and if left unchecked, it will continue to develop, and the skin will break down underneath and lead to an ulcer in our diabetic patients. So these notions that just because you see somebody and they have equinus and they don't have any symptomatology, when you see them, it's just not really understanding the forest for the trees, in my opinion. So every single one of these pathologies that are popping up on this list have been linked to equinus in the literature. And for example, the heel spur syndrome, plantar fasciitis, there's probably 60 or so articles. And if you look at the trend in the literature on plantar fasciitis and heel spur syndrome, for chronic refractory plantar fasciitis now, the surgical treatment now, there's probably 15 articles out now since the last 6 or 7 years that are recommending just doing a gastroc recession to treat chronic refractory plantar fasciitis and not even touching the heel at all. And so when I'm talking to patients about this, I kind of bring that up and tell them, there's a very little chance you have to have surgery, but that just reinforces how important the calf is in plantar fasciitis. And if you have to do that surgically, if you have to deal with the calf surgically, you should certainly have to deal with the calf non-surgically as part of the overall treatment plan. But I can give you articles that link all these pathologies, which is pretty much everything that we see that is biomechanically related that has an association to equinus. So if you have a patient that has one of these diagnoses and they have an equinus deformity, then treatment of their equinus should be part of their overall global treatment plan. I think it's important to understand the biomechanics of equinus so that you can understand how much damage it causes to the foot and lower extremity. A lot of it starts from this article from Thordarson in '95, which was a great article where they took cadavers and they just pulled on different structures, tendons especially, to see which things elevated the arch and which things flattened the arch. So in the sagittal plane, they were looking at the talometatarsal angle, and by far the primary arch deformer was the Achilles tendon. The more you loaded the Achilles tendon, the more the arch flattened. On the other end of that, the primary arch augmenter in the sagittal plane, by far, in a way, is the windlass mechanism. The windlass mechanism elevated the arch more than all the extrinsic tendons to the foot combined. And this is something that should hopefully give everyone on the call pause to cutting the plantar fascia for those chronic refractory plantar fasciitis patients, because it is a devastating effect. It may certainly help the heel pain. There's no question about that. Well, there is a little bit of question about that in literature, but for the most part, I think it's pretty well established. It does help the heel pain, but it definitely has a profound biomechanical effect on the foot. And Thordarson even said that in his article. But if we look at the sagittal or the transverse plane, which was the talonavicular alignment, the more you load the gastroaxilleal complex, also the more the arch flattens. But in the transverse plane, this is where the posterior tibial tendon becomes a primary arch augmenter, whereas in the sagittal plane, it's the plantar fascia. Jeff Christensen wrote a series of articles in the late 1990s, early 2000s that are, I think, really profound. And there were 5 articles, and each one of them, they all related to the medial column of the foot. So what he did was he took cadavers and he put sensors on the first metatarsal, the first cuneiform, the naviculum, and the talus, and did different things to the foot to see how those different things that they did to the foot affected the medial column of the foot. In this first study, what they did was they pulled on the pronatus longus with increasing load. So as they pulled on the pronatus longus more and more, they saw in the frontal plane, they saw increasing eversion of the first metatarsal, the first cuneiform, and the navicula. In the transverse plane, they demonstrated that as you load the pronatus longus with increasing load, you see increasing adduction of the first metatarsal and increasing abduction of the navicula and the cuneiform. In the sagittal plane, there was increasing plantar flexion of the first metatarsal and first cuneiform with reciprocal dorsiflexion in the navicula. And so in this picture, you can see this cross-section of the foot, and you can see the pronatus longus coming across the foot, inserting into a plantar lateral aspect of the first metatarsal cuneiform joint. And so what's happening is that the pronatus longus acts as, influences the medial column as a series of links. And the pronatus longus is everting the medial column of the foot and the central column of the foot. And the pronatus longus fires in the second rocker gait. And basically what it's doing is it's taking the foot from being a mobile adapter throughout the first rocker gait and then converting it to a rigid lever in the second rocker gait for propulsion in the third rocker gait. So the pronatus longus is a concentric contracture during the second rocker gait to stabilize the foot. By everting the medial column of the foot into the central column of the foot. It also creates a reciprocal supinatory moment on the hind foot when it does that. And this is a really important concept to understand, is that the pronatus longus and the plantar fascia works in conjunction with the intrinsic muscles of the foot and the posterior tibial tendon. Those work together to prepare the foot for propulsion. And if you have a deficit in either the plantar fascia or the pronatus longus, that's going to result in a pathological situation. So in part 5 of the study, they looked at what happens as you load the Achilles tendon with increasing load. So you increase the load on the Achilles tendon. That was shown to dampen the frontal plane action of the pronatus longus. So the pronatus longus cannot evert the medial column of the foot into the central column of the foot like it normally does. And that led to unlocking of the mid-tarsal joint, and specifically hypermobility. I know hypermobility is kind of a controversial term, and some people don't like that terminology. I think if you don't like hypermobility, instability is kind of a different, substitute word you could use here. But hypermobility is what the authors used in their article. And specifically, they saw flattening of the arch at the NC joint. And if you just think for a second of every flat foot x-ray that you see every single day, when you see an NC sag, and it's important to understand why those NC sags are there. The NC sags are not just happenstance, like some people get it and some people don't. That's not what's happening. The NC sag is directly related to the influence of a tight gastroaxilleal complex, causing, this is where the distal compensation occurs within the foot at the NC joint. So as you're taking a step and moving your body from behind your foot over the plantar foot and forward, and your ankle joint is being limited because of a tight calf muscle, what happens is the arch flexes downward through the NC joint to allow your body to move forward over your plantar foot, despite the limitation of ankle joint dorsiflexion. And this is where all the havoc comes from that equinus causes. And if we think about that orthotic statement that Hill made earlier that I said was inaccurate, it comes down to this. It's because the calf, when you have equinus, is driving the arch down through the NC joint. And you have an orthotic that you have made that is trying to support the foot externally and push the arch up or hold the arch up. Well, they're fighting each other, and the arch and the foot is the battleground. So, of course, the patient's going to come in for their first orthotic check and tell you the arch is too high on my orthotic. And we'll talk about that here in a second, why that's, I'll give you a good example of that here in a second. So specifically, what we see is plantar flexion of the talus and navicula, and dorsiflexion of the first cuneiform and first metatarsal. And again, this kind of goes back to those people who are doubters about the influence of equinus on the foot, and that maybe it's just a normal variant. And like I said, it's not seeing the forest for the trees. But Christensen said, in clinical practice, the early destructive influence of equinus is often not appreciated. Instead, we are usually faced with the end results of equinus effects. And we know as physicians that it is so much more effective, it's so much cheaper, it's so much better for our patients if we can do preventative medicine instead of having to treat something. So if we can prevent a problem, we're going to be better off than trying to treat a problem. And if we're going to have to treat a problem, we want to catch it earlier rather than later. So this is a cartoon drawing of what happens with equinus. The top is the normal foot, the bottom's equinus. I want you on the sagittal view to watch the NC joint, what happens as on the equinus foot, how it gets driven down as the tibia rolls forward over the talus, and the foot comes up into the third rocker and the heel comes off the ground. Now we're going to look at a coronal view, and you'll see what happens as the NC joint gets driven down. The calcaneus goes into valgus and perpetuates the flattening of the arch. And then this frontal view, I want you to look at the first ray axis. And you'll see as the first ray axis gets pushed up, but it also goes into a triplanar deformity. And that should ring a bell with you with the paradigm shift that's occurred in bunion surgery, where we becoming a triplanar deformity and having to deal with all three planes in our bunions. This is where that triplanar deformity comes from. It comes from this instability of the medial column of the foot. So not only does the first ray go up, it also rotates in the frontal plane and the transverse plane. So hence the triplanar deformity for bunions. I'll just let this run through one more time so you can see, like in that side view, you could see the NC or the first metacuneiform instability where it widened on the plantar aspect of the joint. Here you can see the talar go into increased declination as the arch flattens due to the tight calf muscle. And then here again, watch the axis of the first metatarsal as it really becomes a triplanar deformity compared to the normal, but without the tight gastroaxilleal complex. And Christensen said that the authors strongly recommend careful clinical assessment and appropriate treatment of equinus in patients with biomechanical deformities affecting the first ray and midfoot. And I agree with that completely. Jim Amos had this study that he did before he got out of private practice and went into the corporate world, which he just retired from, like I mentioned earlier, where he used slow motion photography to watch patients walk. And I tend to lean towards orthopedic biomechanics, so that's where the term rockers come from, more so than podiatric biomechanics. I think it just makes more sense to me. So he's also using the term rocker a lot. But there are direct forces that are attributed to tightness of the posterior muscle group. So those include forces on the gastrocnemius muscle, the gastrocsoleal myotendinous junction, the Achilles tendon itself, the Achilles tendon insertion, the calcaneus, and plantar fascia. So those things are directly related to tightness of the posterior muscle group, will cause increased forces in those specific anatomical areas. The indirect forces are what we talked about a second ago, where we have tightness of the gastrocsolial complex, limiting the second rocker of gait. As the body then passes over the planted foot, that causes increased leverage forces upon the foot and ankle, which causes increased stress and strain on the joints, ligaments, and tendons, which then results into pathology. When I give this lecture a lot, and particularly to students and residents, and I always like to say, when you're doing a lapidus, just look at the dorsal first mecaniform ligaments, how unimpressive they are. And if you think those kind of wimpy, insufficient ligaments can withstand this significant pathological forces that are occurring through the medial column of the foot due to a tight calf muscle, it's just not going to be able to hold up to that kind of strain. And that's going to lead to insufficiency and then hypermobility and instability. So this is a patient where Amos was using the slow motion photography and showing that this fourth rocker gait developed right here in the middle part of the foot. So as we're in the second rocker here, there is a sag occurring, and it's exactly where Jeff Christensen said it would be. It's right at the NC joint. And then as we go into the third rocker of the gait, the gastroc is firing and pulling the heel up off the ground, that perpetuates that fourth rocker of gait into the NC joint, and that just gets worse. And Amos showed that this only lasted for 1/10 of a second. The problem is how many steps a day are we taking? Hopefully 10,000 for our health, but thousands of steps per day over a period of years, that leads to this occult, unrecognized overuse of imbalance, which leads to damage of the foot and ankle. He also looked to see what was happening at the knee. So at that exact same time, in the second rocker of gait, when the ankle joint was being limited in dorsiflexion, the knee goes into full extension, which is exactly the worst thing that could happen at the wrong time. That increases the direct and leverage forces on the foot and ankle by twice the force in half the time. So it just has this compounding effect on the amount of abnormal stress and strain that's being placed both proximally and distally from a compensation standpoint. And Amos concluded that merely being human in places is a risk of developing acquired non-traumatic foot and ankle problems. This damage is mediated through our unique anatomy and the gastrocnemius that tightens for a number of reasons. That's a whole other lecture. It takes some stuff out of my normal lecture to keep us from being too late on this. So let's talk about conservative treatment real quick. From a non-surgical standpoint, I think there are a few questions that you have to answer to really make a sound decision on how to treat equinus non-surgically. And we'll go through these questions here in a second. First, what stretches? Does a tendon stretch? Does the muscle stretch? Does it really matter? This is a very controversial topic in the physiology world. There's a lot of articles that will support that the tendon stretches. There are a lot of articles that support that the muscle stretches. And then there are a lot of articles that say neither one of them stretch. This was from Clinical Biomechanics, which I think is a very high impact journal factor rating journal. So it's a journal that has lots of clout, if you will. And I think it's a very reputable journal. It's something that I try to go through once a month and pull articles out of. So what they did in this study was they took patients and they had them stretch, and they looked at the displacement of the tendon with ultrasound and the displacement of the muscle with ultrasound. They also looked at for change in range of motion. And what they showed was the range of motion increased significantly with stretching, but there was no change in the tendon displacement. There was no change in the muscle displacement. And the authors concluded that the range of motion was most likely due to altered tolerance to stretching by the nociceptive nerve endings, but there was no effect on the muscle or tendon units. And I don't really care. I'm a clinician. You are clinicians. What we care about is increased range of motion. How we get the increased range of motion doesn't really matter that much, just as long as we get increased range of motion. So I don't care if it's coming from the tendon or the muscle, or if it's coming from altered tolerance to the nociceptive nerve endings. What I care about is increased motion. So how long should you stretch? Well, Good luck. It ranges from 30 seconds to all night based on the literature, so we really don't have a lot of guidance. The best article that we have is this article from the British Journal of Sports Medicine from Radford in 2006, where they did a meta-analysis of stretching to try to determine how long you need to stretch. And basically what they looked at was less than 15 minutes, 15 to 30 minutes, and greater than 30 minutes. The problem was the greater than 30 minutes category was underpowered, so the authors couldn't make any definitive statements. They could only suggest a trend, and the trend was the longer that you stretch, the more the range of motion. So I looked at these numbers and I was like, well, that's not a ton of more motion that I would like to see. So I doubled this from 2006 when this article came out. So I just went up to an hour, and I can tell you anecdotally for the last 15 years of using an hour per day works very well. Could you maybe get by with 30 minutes a day? Maybe. I don't know that for sure, but I do know an hour works with just thousands of patients using a brace for an hour per day works well. Radford said calf muscle stretch would provide a small but statistically significant increase in ankle joint dorsiflexion, and that it is recommended. So if the position of the foot matters when we're evaluating equinus, does it matter when we're treating equinus or stretching for equinus? And this is what Johansson looked at in this study. And this is a really important concept to understand. So first, the patients, they measured right and left, and they all started at 4.6. So the right side and the left side were the same, and that's going to be important here in a second. But one of the things that they showed in the study is when you stretch in a pronated position, the knee is more flexed than when you stretch in a supinated position. And that's because of the screw home mechanism. And that may ring a bell to you, but the screw home mechanism is due to the external rotation of the tibia that occurs when your subtalar joint supinates. And the only way you can fully extend your knee is if your tibia externally rotates, and that's why it's called the screw home mechanism. So supination of the subtalar joint leads to external rotation of the tibia, which then leads to full extension of the knee. And because we're talking about the gastroc being the culprit in most of these cases, that's critical that the knee's in full extension to maximize our stretch. The next thing that they showed in this study was that there was a significant amount of motion occurring in the metatarsal joint when the foot was pronated compared to when it was supinated. And we know that it's never really a good idea to have excessive motion going through the metatarsal joint. We want to isolate that motion to the hind foot, particularly when we're trying to stretch out the posterior muscle group. So really it's important to stretch in supination for dorsiflexion to occur at the hind foot and allowing for external rotation of the tibia to lock the knee to full extension via the screw home mechanism. And that way we're going to maximize our stretching of the gastrocnemius muscle. Does stretching work? Well, this was an article where they looked at stretching for runners. The baseline was 5 on the left and 5 on the right for this group of runners. And they showed a 200% increase in range of motion with stretching. So significant improvement in stretching. And because they were runners, I asked them about their running times. And this is a whole other different lecture I give on equinus and athletes. I've been the team podiatrist for the Indiana Pacers for about 20 years. So this is something that is kind of near and dear to my heart, the role of equinus with athletes. I'm actually speaking at a Notre Dame sports medicine conference in a couple of weeks before the Notre Dame-Cincinnati game. They have a really neat event I'll be speaking at on equinus and athletes. But they showed in this study that as the patient's flexibility increased, their running times improved. And that's actually a very commonplace if you take some time to understand what's going on in the literature in regards to static stretching and athletic performance. So why not just use manual stretching, the runner stretch? Well, the problem is it's, I think, a compliance issue. And if we just use 30 minutes per day, it's 30 minutes per day per leg. And it really, if you look at the literature, most of the literature that looks at stretching for equinus or the calf muscle is about 6 weeks. I think it takes probably more like 8 to 12 weeks to fully stretch out the calf muscle. And there's just a lot of ways to do this wrong. So like in this example, bending too far at the hip. In this example, the back knee is bent, and here the back heel's coming off the ground. And oh, by the way, make sure that you're stretching in supination and not pronation. I mean, good luck. We have a hard enough time trying to get our diabetics not to put weight on their ulcers and prevent their legs from being cut off, let alone getting somebody to do this every day for 30 minutes per day, per leg, and not doing it incorrectly. It's very hard to do it correctly, even if you know what you're doing. So I think it's more just a practicality issue and a compliance issue with the wall stretch or the runner stretch. Night splints, the problem with night splints is that you have to sleep on your side with your knee bent. So automatically that eliminates them from doing anything. They're not doing anything to stretch the gastroc complex. That's how I came up with the idea for the Equinus brace. I had posterior tibial tendonitis from running, and I didn't want to stop, and it wasn't getting better despite everything I was trying. So I was like, all right, I'll stretch with a night splint. And I woke up at 2 or 3 in the morning, and because they were terrible to sleep in, and I looked down and I was like, this isn't doing anything to my gastroc. This is a complete waste of time. It has to go above your knee to lock your knee into full extension. Otherwise, this is absolutely doing nothing. So that's where I came up with the idea. So you were like, well, I'll give my patients a night splint and have them do this. And then, the left is obviously not doing anything. That's just as bad as sleeping on your side with your knee bent. On the right, it's not a bad attempt, but the problem is your knee has a natural state of flexion to it, and that if you're going to dorsiflex the foot and extend the knee, you almost have to be forced to do that. So the right's not bad, but it's just not ideal. Our dogs are going bonkers. Sorry about that. Dorsal night splints are worse for all those same reasons, but they also allow the forefoot to plantar flex relative to the rear foot. So they allow for the plantar fascia to relax instead of dorsal, in addition to all those other problems that occur with posterior night splints. So ideally, from a bracing concept standpoint, we want something that goes above the knee to lock the knee into full extension. We as podiatrists measure everything, but we give patients night splints and tell them to pull as tight as they can, and that leads to overstretching. So if we have controllable hinges at the ankle joint to allow for precision of treatment based on our clinical exam, that would be beneficial. And then also to stretch and supination. So by doing that, we engage the windlass mechanism to supinate the subtalar joint, creating that dorsiflexion, primarily in the hindfoot, not the midfoot, also externally rotating the tibia, allowing the knee to go into full extension via the screw home mechanism. So that's where the Equinus brace comes into play. This is the brace that we're talking about tonight. It's the only brace that goes above the knee. We have patents on several features of this brace. So first, there's a lever on the back that allows you to extend this, and the knee goes between these 2 straps here on top. There are 2 hinges on the current version. We have a newer version coming out later this year, early next year. We'll have 5. We have a pediatric version of the brace also, or a small version for up to about size 6, but it has 5 settings on it. So these settings are at 90 degrees and then plus 10 degrees and plus 20. So I keep patients at each setting for 1 month, and then I see them in the office. I measure them. The staff adjusts the brace, and then we talk about things to look for as we go from one setting to the next. There's also this toe wedge that is Velcroed onto the footbed, so you can move it from right and left. You can also adjust it. This is a 60-degree wedge, so that's going to dorsiflex the hallux, and the hallux is about 28% of the plantar fascia. So when you dorsiflex the hallux, it is enough by itself to engage the windlass mechanism fully to supinate the foot. That's been shown in the literature to be pretty reliable. Now, if you have somebody that has hallux limitus or hallux rigidus and restricted range of motion, all you have to do is pull that wedge out more distally from their toe to reduce the angle from 60 degrees to wherever it's comfortable for them. Let's say they have 20 or 30 degrees dorsiflexion available. So those are the key components of the Equinus brace. Like I said, I have them wear for an hour per day. I have them keep it in each setting for a month, and then we adjust them monthly. And so it takes about 3 full months for treatment. So I'm doing this in conjunction with lots of other things. From a billing and coding standpoint, you have to have proper documentation, and this is some of the documentation for the physical exam part. You have to show that this isn't a fixed deformity, and you have to say that you measured with a goniometer, the ankle joint dorsiflexion with the knee extended and the knee flex. You also have to include total ankle range of motion, both plantar flexion and dorsiflexion. So this is a template that we made, and I'm going to give you the templates I use in Athena here in a second. When you're treating Equinus as part of the treatment for, let's say, posterior tibial tendon dysfunction or whatever, you obviously need to have those pathological physical findings in there as well. When the brace is being used for pathology that has an associated equinus like Achilles tendonitis, posterior tibial tendon dysfunction, metatarsalgia, pronation, or acquired flat foot deformity, the diagnosis code for ankle contracture, so that's M24 571 or 572, should be linked to the CPT code for the brace. If the brace is being used for plantar fasciitis without an equinus deformity, so you can use this for 3 different diagnoses codes, then it should be linked to the plantar fasciitis diagnosis of M72.2. If the brace is being used for plantar fasciitis with contracture of ankle contracture deformity, it can be linked to either one of those diagnoses. Always documentation is critical, especially for ankle contracture deformity diagnosis. Please note that the ICD-10 for short Achilles tendon is not listed in the LCD for L4396, which is what the equinus brace is L4396, which is used for the surgery. So if you're doing a gastric recession, that's what's used for surgery, but for non-surgical, you want to use the ankle joint contracture codes. These are the Athena templates that I have created that I use, and you are more than welcome to copy them and put them into yours or use mine. I just use my DOT, PAD, my initials, and then Equinus Exam Mini. I use Mini after my templates because there are many templates in my mind, kind of from our older system that we used to use. So that's for the Equinus exam. That'll drop everything you need in there, and there are presets that I have them set to, and then you can adjust them just by click there. You can click on them and change whatever you need to. And then for dispensing the brace, I have a template under .PAD Equinus Brace Mini that you can put in. I put it in the plan section. It has all the proper documentation you need for the brace itself. And then, like when you're seeing patients to adjust the brace and check them and measure them, I will change the measurement in their physical exam. Like let's say they're at their first setting at 90, and before they were less than 90. So then I'm going to change it to equals to 90 in their physical exam. And then this next template has some different drop downs that you can change it to, like adjust the brace to plus 10 degrees deformity based on clinical exam or something like that. So those are the 3 templates I've created, which you're welcome to use in Athena. So here are the contracture codes, or plantar fasciitis codes, the LCDs. You have to meet all of the criteria for the ankle joint contracture codes. So 1 through 4 to use the M24 codes, and then 5 is this plantar fasciitis, which would have to be documented in your physical exam, or you can have both. The LCD, the correct code for the brace is the L4396. So we also build the hinges L2210 times 2 per brace for non-Medicare patients. And this tells you how, with Medicare, we weren't able to get the hinges, but our billing consultant is Paul Kesselman. He recommends billing the hinges on everybody but Medicare patients. So for non-Medicare patients, you bill L4396 right and left on separate lines as 1 unit, and then L2210 right and left on separate lines as 2 units each. And then you can link it to the appropriate codes that are going with why you're using the brace. If you have a patient that comes in with unilateral heel pain, should you stretch both sides or not? Well, I guess my question back would be, do you make one orthotic or 2? We know from the pennation angles, which are the muscle angle fibers of the lower extremity muscles, that they're always the same. And if you look at Macklin's study, they both started at 5. Look at Johansson study, they both started at 4.6. And then recently this year, I published a study with our group in JAPMA where we looked at the bilaterality of equinus of 249 consecutive patients. And if you look at the numbers here, there's no difference between right or left. And there's not going to be a difference between right or left unless there's a reason for it, like they've had a previous rupture or previous surgery on one side, not the other. So our conclusion was the prevalence of ankle equinus in the sample was higher than previously reported, and nearly all of those patients had bilateral involvement. The data suggests that many people attending foot and ankle specialty clinics will have ankle equinus, and select groups, diabetes, increased BMI, and overuse symptoms are increasingly likely. That was a conclusion from our study. We had a pretty good cohort to look at. So if you treat one side and not both sides, and this is how I explain it to patients, you're going to create a functional limb length inequality, which is going to cause back and hip problems. So I have very little pushback on having my patients get 2 braces. Like I said, we build right or left. They wear them for an hour at a time at the same time, so they're stretching both legs simultaneously. They're not putting on, if you think they're going to use one brace on their symptomatic side and then use the brace on their unsymptomatic side, they're just not going to. The compliance isn't going to follow through for 2 hours. But they'll wear 2 braces for an hour at the same time without much resistance, but you need to explain why it's important. So that orthotic-equinus war that we talked about, here's what I was talking about, that NC sag, and then here's the orthotic pushing the foot up. So you have this deforming force of the foot on the leg coming down through the foot, through the NC joint, driving the arch down, and the orthotic pushing the arch up. When your patients come in and say the arch is too high on my orthotic, it's not like you took a bad impression or the lab just randomly made the arch too high. It's you have the superior deformity that hasn't been treated. And if you treat it and you remove that deforming force of the leg onto the foot, then the foot can tolerate the type of control that it really is required to actually do something to support their arch externally. Another thing that's important is shoe drop. Shoe drop is the height difference of the heel to the ball of the foot. And some companies understand this, but a lot of them don't. If you're treating somebody for equinus and you're stretching them for a day, but they're wearing a 16 millimeter shoe drop, then that's really fighting your treatment. I really try to get patients into what I call a mid-range drop shoe, and that's between 4 and 8 millimeters of shoe drop. I'm not really affiliated with any shoe companies, but the shoe companies that fall in that category most frequently are Saucony and Brooks. You do not want to take a patient that has an untreated equinus and put them into a 0 drop shoe, because that's going to cause Achilles tendonitis and or metatarsalgia. Now, once you get a patient stretched out, and if you want to put them in a Hoka or an Ultra 0 drop shoe, fine, but get them stretched first. And that also applies to dress shoes for men and women, so you have to have a conversation about the type of shoe. So just my conservative management, 1 hour per day seated upright. If you have them seated upright and you have them raise their legs a little bit, they'll also stretch their hamstrings. And hamstring tightness is definitely linked to a lot of foot pathologies, particularly things like plantar fasciitis. So you can kind of get the whole posterior chain stretched out if you have them elevate their foot slightly, like on a recliner, or maybe a pillow under the foot if they're on the couch. That will stretch their hamstrings and the posterior muscle group. You want to stretch both legs simultaneously if both legs have equinus, and as we talked about earlier, most of the time they do. I keep them in each setting for a month. I check them, I measure them, make sure they're ready for the next adjustment, then I'll adjust the brace. And then you have to get them through the full 3 months. I like to see them, once they're fully stretched out, be at least above +5 is kind of my low point. And then you have to talk about maintenance therapy, because the natural process of walking upright, the anatomy of the calf muscle, and aging will lead to recontraction. It will recontract, and that's why anywhere between 20 and 30% of the patients that have a posterior muscle lengthening, it doesn't matter how you do it, whether it's a TAL, a Strayer, or a Baumann, or a proximal head recession, that there's a consistent 20 to 30% contracture rate, is because of those things I just mentioned. So I put patients on maintenance therapy, and maintenance therapy for most people then becomes 2 nights per week of the brace for 1 hour. And I usually have them spread it out like Monday, Thursday, or something like that. Now, there are 3 groups of patients that have higher demand from a maintenance therapy, and those are athletes who are like serious athletes, like high school, college, professional athletes. So they're going to be needing the brace usually 3 nights per week. So I have them do Monday, Wednesday, Friday. Diabetics. So diabetics have what I call a metabolic component to their equinus. So they have glycosylation of the tendon that leads to cross-linking over and above their functional equinus component. So they also require 3 nights per week. So I always say that we miss the 4th leg of conservative treatment on our diabetic patients. We do a great job with diabetic foot exams, diabetic shoes and orthoses, and preventative foot care, but we leave this untreated equinus that we know causes all kinds of problems with Charcot, we know causes all kinds of problems with forefoot ulcers, and we should be treating their equinus simultaneously from a preventative standpoint. And then the 3rd group is rheumatoid patients that I mentioned earlier. That was from the newer Jastify article. I would also recommend having them use maintenance therapy 3 nights per week instead of 2. Here's my contact information. I'm happy to answer any questions you may have regarding the brace or. And then if you'd like a PDF of my lecture, this is a QR code. All you have to do is hold up your phone, and it'll send you a link to my Google Drive to download that lecture.
That's great, Patrick. Thank you. So, and can you go back to your contact information? Because then we got so many people, we won't open up for question now. But if you don't mind them reaching out to you and asking questions about equinus, your brace, your theories, the papers, would be great.
And one other thing I forgot to mention, my son Joey's on here. He can help get your offices set up with a brace. He's really good about training your staff how to educate patients. That is super important from a compliance standpoint, is getting your staff trained on how to educate patients on how to use the brace. And he'll take care of all that. He does a really good job. He's also available to answer. He knows as much about equinus as I do because he's been working on this with me for so long. So he's really well versed in it.
Excellent. Well, thank you, Patrick, for taking the time to do this after our long workday. We appreciate it.